Thank you so much for having me here, and it's intimidating to be the first speaker of the day. You don't know what the rest of the agenda is, but I'm happy to talk about the topic that I'm supposed to talk about. The title of my talk is Design Thinking and Innovation. As we think about the global entrepreneurial ecosystem, my lens is healthcare. I've been in healthcare for a fairly long time. I'm a professor here at School of Medicine. I'm part of a program called Biodesign, Biocenters for Biodesign, which is a design thinking-based program to teach young professionals this methodology that we call Biodesign for Medical Device Innovation. And this methodology has become the Stanford medical device innovation across the world, and the whole community has been built around it. So it fits well with the theme of this event, and I'm happy to share a little bit of that with you today. So this is the vision of the center that I'm part of. It's to be a global leader in advancing health technology innovation, and the goal is to really improve lives everywhere. And essentially that really captures the goal of every entrepreneur out there. Our audience is Stanford community, faculty members, students, researchers, fellows, but also global fellows and faculty, which hopefully I'll have a chance to briefly talk about. Let me set this up. How many of you in the room are technology folks with technology background? Can I see a show of hands? Quite a few of them. And Silicon Valley is just full of people like this. I'm an engineer myself. And I was in the industry before I came to Stanford as a faculty member. And often what I saw on the industry side was this desire to apply technology to problems where technology came first. Technology was looking for solutions in many of these cases. And I saw some successes, but often failures that were catastrophic and actually didn't really lead to the results that we all hoped for, given the investment that we were making. In healthcare especially, there has been this recognition that technology push, which is the norm in most technology areas, it doesn't really work. And I think there is a need to start with the need first. Which is essentially the root of design thinking, where in the 5 steps how many are familiar with design thinking? Quite a few of you. It's a very popular field, and most business schools today teach it. But 30 years back, that wasn't the case. Design thinking as a language, as a terminology, as a framework, has really come into vogue in those 30 years. And the fundamental point about design thinking is that you got to really understand your users. You really have to understand the beneficiaries who are going to benefit from your product or solution first. So that it's got 5 steps: empathize with the user, define the problem that you're trying to solve, ideate around it, prototype, and then test, and then go back. So it's a very iterative sort of approach. And it works remarkably well, as the last 30, 40 years have shown, for technologies that have a single phenotype of user. iPhone that's shown over there is a really good example where that's what Steve Jobs said. I just watched a video last night of Steve Jobs where he was talking about how he wanted to start with what is it that the user needs, what is the user experience first, and then apply technology to it rather than the other way. When he was away from Apple had moved away from that, and he felt that was a big mistake, and then he brought Apple back to it. And essentially, Apple products are a good example of how, if you start with the understanding of the need of the user, in this case, people like you and I, you'll come up with a solution that hopefully serves the needs the best. So design thinking works really well in these kind of situations. But what happens when the user is really multifactorial, multifaceted, many variables involved? When you have healthcare providers, you have insurance companies, you got Wall Street, you got fearless leaders involved in it, and you got doctors and patients way in the corner. When you have such a diversity of quote-unquote users, all of them actually influencing the solution that must solve the problem of healthcare, how do you apply design thinking? And to deal with that complexity, we came up with this process called biodesign. This is about 20 years back, founder of biodesign, Dr. Polyak and others, defined this process. And it's essentially design thinking, but applied to the healthcare setting, especially medtech setting, where there are 3 steps: identify unmet needs, invent solutions around that, and implement. Simple 3 steps, but if you look at the sub-steps within those, you'll start to see some details. And then there's another layer that I'm not going to show here, but essentially there is a big part of it is needs finding and needs screening. That is really the central piece of this entire methodology. What this process is unless you have truly understood the needs of your complex, this eight-headed monster called healthcare, needs of that system, that as a user, you should really begin inventing solutions around it. And only after that you've done that, after you identify the needs and you prioritize the needs, and I'll talk a little bit about that process in a bit, should you start inventing and then go on to implementation. But do you see those cycles going in each of the steps? And that's the other point about this methodology, that you don't get to a final solution in one shot. You learn. As you develop solutions and you implement the solution, you learn from the quote-unquote market, the clinic, the patient, the physicians, the healthcare providers, and you incorporate that in your next iteration. So the solution is never perfect. It keeps getting better and better and better. Those of you who are working on artificial intelligence in healthcare, it'll be good to remember that. But that's essentially the process. Let me quickly go through some of the stages. So stage 1 is really needs finding within the identified step. Here what we do is we spend a lot of time in the clinic observing healthcare providers and patients and their families and the nurses and the techs, hundreds and hundreds of hours over 2 or 3 months, where we really understand where the challenges might be for all of these stakeholders. Every observation that's made about the hurdle that the system is facing in providing good care to the patients is basically written down. And those observations lead to what we call need statement. The need statement is a very structured way of capturing the unmet needs. And it goes something like this: a way to solve a particular problem for a particular group of customers in order to achieve a particular outcome. It's a very well-structured sort of statement. It really captures the 3 essential parts of a need. So an example is a way to perform point-of-care testing for patients with certain diseases. So now you're defining your customer very, very well. And you're also defining the outcome that you want to achieve. And that outcome is really as important as the group of people that you're solving the problem for, and what is it that you're trying to do with that group of customers. Stage 2 is need screening. One of the defining characteristics of the biodesign process is that you don't get wedded to one thing early on. You do lots of ideation. So even before you get to ideas, even for needs, you make lots of observations. Our fellows end up making 600, 700 observations in the course of 3 months. And then they identify needs, and those needs are usually hundreds, low hundreds. And then from those, based on a set of criteria that are set up front, they pick the needs that are highest priority. And those needs could be picked on basis of how important are the needs, how urgent are they, how validated are they, what is the capability of the team, how easy is it to do a solution around that, number of different factors they consider, and then they come up with top needs that they ultimately want to go after. And screening approaches, some of the characteristics that I just mentioned. And then once you have a top need, you actually create a needs criteria, must have and good to have. This is something that I often, I'm part of the global biodesign leadership, and a lot of global programs I'm involved in. I see this temptation, and I think it's in Silicon Valley as well. It's no different, but especially in the global setting, there's a temptation to add everything that you can do. The solution should have everything that any stakeholder has ever asked. And I think it's really, having a must-have and nice-to-have that would determine how, what the solution ultimately becomes. So I'm going to skip through the rest of it, these concept generation the same way. We come up with lots of concepts, and then you filter those concepts, And then screening is iterative, which is the point that I had made earlier. I see a time warning there, so I'm just going to skip through it. I want to get to the outcomes. So the big picture for us is we have trained a lot of fellows, a lot of students, a lot of fellows and faculty globally, and the outcome has been, this is a little dated slide, we have 50 companies by now in the last 18 years who have lots of employees and lots of investments that they've raised, but this is the metric that's most important to us. I think this number now in 2019 is 2 billion plus patients, and if you notice how it's building up, this is how innovations make impact. They build up over a period of time, and we expect in future tens of millions, if not hundreds of millions of lives that we will be able to touch through innovations. Our real product is this, our people. They are the ones who are doing this. Not only when they're in the program, but they leave and they go on to do other things, and we track their evolution, and we're extremely proud of that. So I'm going to pause here. I also had some slides on the global community that we've built, but I'm going to take any questions if there are.
So when you observe patient doctor interactions, you see what's actually going on, but you don't necessarily see what's not going on. So for example, one of the problem that my company is facing is the fact that doctors are not aware of the mental health and behavioral health conditions that the patients have. They don't ask. So you won't see that interaction. You'll see the absence of that interaction.
So I think that's a great point. You don't want to limit just to the clinic. As healthcare is moving into the communities, into homes, which is how it used to be in 40s and 50s, you want your observations to actually go to those settings as well. Wherever the problems are occurring, you got to do immersion, clinical immersion, but it can do immersion for the our home. So that's a point very well